these conferences, they have different types of lectures. Some of them are full professors, some of them are assistant professors. You can tell because they don't have any financial disclosures, because they don't have association with industry and sponsors. And then you have normal people who aren't even professors, but just a doc like me, basically. They have practice, they work at a place that has a name called Mayo Clinic, but they're just some random doctor who sees patients. But I don't like getting talks from them because I feel like, so one introduced by saying that she has a big topic, there's no way she covered it all, but she'll give us a whirlwind tour and hit upon the high yield points. Well, I mean, I don't care about high yield points. I don't care about details or facts or this and that. I care about improving my understanding. That's why I go to these things. See, reading is very good for learning up details, assuming you have the sort of motivation to read, because many people don't read. That's why they go to conferences. So yes, you could say they're covering a broad swath of people. They gotta appeal to the general audience, right? Cover everybody. But the point for me to go into these things is you get these great minds and you hear them talk about stuff, and they help you think about stuff differently. Like I remember in one conference before with cardiology, one guy was mentioned to talk about topics. We have a implantable device that helps determine someone's going to go into heart failure. He says the issue is not the device. The issue is us humans, us, the medical profession, because the turnaround with this open loop is so long that there's no point, basically. So you get the reading from the device, takes a day for your medical assistant to contact you, the doctor, takes another day to get reached the patient. And finally, day 3, you call the patient, like, yeah, doc, thanks for checking on me. I'm fine. They're taking good care of me in the hospital. The whole point is you figure out this early enough so he changes medication so he doesn't go to the hospital. But anyways, so there's her, right? Talking about these high yield points. And then you have these other docs who really emphasize the theory or how you think about stuff. Like, remember my lecture in residency about headaches? One neurologist giving us a talk about headaches. Gave us this log burning paradigm. It really helps you think about it because there's the original headache. And then you started adding all these medications to try to treat the pain. Tylenol even, ibuprofen, harmless medications. But once you get too much, you have a type of headache just from medication overuse. You're just throwing more stuff onto the fire and they're starting to burn as well. Not helpful. And then you have a set of minds who are really smart, who come together, and you see the brilliance of that. I saw it this morning. So one neurologist had a question about inheriting a patient who was going to get treated for Parkinson's disease. And he's on a really high dose of medication called cinnamon, much more than standard. And his question is, what do I do about this? Are there toxic effects? Well, the panel discussed this. All these lecturers who have professorships, and they talked about how to try to wean him off because it really isn't useful. You could have side effects, you don't have to. There's no upper limit, it's just not beneficial, has more risk of adverse effects, and how you work with the patient, try to get him off, because it's really hard. You gotta work with the patient. But then guess what else? Afterwards, some old guy wearing some, gray suit, all the lecturers are wearing their, dark colored suits because that's Mayo Clinic style. He goes up to the microphone and says, I want to add that, maybe he's actually wasn't treating Parkinson's, but something called Perry syndrome, which you do treat with high dose of levodopa. Come talk to me, whoever asked that question. Me and the rest of the audience, 90% of us did not know who this old guy was. Well, guess what? Everybody else did. Everybody on stage. He's the guy they mentioned a few minutes ago as the discoverer of the LRRK2 gene. Obviously a brilliant guy. Obviously knows a lot. So even if you have all these experts and everyone's thinking in one direction, you have a brilliant enough mind to realize, wait a minute, maybe this prior neurologist, maybe he was super smart in treating something else called Perry syndrome and you just know what it is. Maybe he's not smart, he just happened to see that it worked when he kept increasing the dosage. But hey, there's something else to think about here. It's not so cut and dry. And I realized that's the inequity and the unfairness of working in the medical field. I work on all these small community hospitals and sometimes you hit upon a good doc and many times you don't. But when you hit upon a good doc who knows what they're doing, it saves the patient so much workup, so much pain and suffering, and maybe the patient can even get better. Because I'm sure nobody I work with at work knows what Perry syndrome is. How can you diagnose something when you don't know what it is? The answer is you can't.